So there are several different means of delivering radiation therapy to the brain. We'll go over those today. Whole brain radiation is your classic radiation field. The entire brain parenchyma is targeted and covered with radiation therapy. This is generally given in a fractionated form, so for 5 days a week over several weeks. The clinical goal of whole brain radiation is to deliver therapeutic radiation dose to the entire brain parenchyma. Potential advantages are the treatment of microscopic occult disease that is otherwise not seen on MRI. Disadvantage, however, is that it can cause toxicity such as hair loss, fatigue, and permanent short-term memory loss. Indications for whole brain radiation include patients with numerous brain metastases, patients with evidence of leptomeningeal involvement, and brain metastases from small cell lung cancer. This is an example of a whole brain radiation field. In general, right and left lateral fields are used to ensure coverage of the entire brain parenchyma. A more modern version of whole brain radiation therapy is to use intensity modulated radiation therapy, which we will go over in a few slides, in order to deliver hippocampal avoidant whole brain radiation therapy. There are currently trials looking at its use. So stereotactic radiosurgery is using highly focused radiation in order to deliver therapeutic radiation to targets within the brain while sparing as much normal brain tissue as possible. Advantages of stereotactic radiosurgery is that because of the highly focused nature of the radiation, there is no cognitive decline generally seen, or very minimal. Disadvantages of stereotactic radiosurgery are that it does not treat disease that may not be seen on an MRI. Indications for stereotactic radiosurgery include oligometastatic brain metastases. In general, less than 15 are commonly can be treated with stereotactic radiosurgery. Benign brain tumors such as meningioma, schwannoma, functional targets including trigeminal neuralgia and essential tremor, and arteriovenous malformation. This is an example of a stereotactic radiosurgery plan. The slide on the left depicts a patient treated with gamma knife stereotactic radiosurgery. The right cerebellar lesion, the yellow line, depicts the prescription isodose line, and the slide on the right demonstrates the patient's follow-up MRI 1 year later. As you can see, the patient had a near total response. 3D conformal radiation therapy is what is thought of when patients receive radiation for several weeks for indications such as glioma or a benign brain tumor. 3D conformal radiotherapy is characterized by the use of image guidance, including CT and MRI. Usually the CT is used to model the radiation dose, whereas the MRI is used for better contrast and delineation of enhancing tumor. As we said, indications include both low-grade and high-grade gliomas, meningiomas. This is an example of a multifocal glioma being treated with 3D conformal radiotherapy. Enhancing lesions are seen in the slide on the right. The panel on the left. The panel on the right shows the tumor contoured in brown color wash. The green represents a safety margin to account for microscopic disease, and the brainstem, which is an organ at risk, is contoured in red. The image guidance is used to determine that sufficient dose is going to the tumor regions at risk, and the normal structures at risk, such as the brainstem, are not being overdosed. Intensity modulated radiotherapy represents an advance in radiation techniques over the past 2 decades. Essentially, the IMRT, as it's otherwise known, bends the dose away from critical structures to avoid overdosing them and avoid causing toxicity. In general, these are IMRT is given in conventional fractionation, so 1.8 to 2 gray per day over several weeks. Indications for IMRT are for tumors that are near the brainstem, optic nerve or chiasm, the retina, spinal cord, or cochlea. This is an example of a low-grade glioma being treated with IMRT techniques. The panel on the left demonstrates a flare abnormality that is contoured, which represents a low-grade glioma. The panel on the right is the IMRT plan, showing that the dose is bending away from the orbits and sparing the retina from dose. So cranial-spinal irradiation is used to target the entire CSF space and the thecal sac in tumors that have a high risk of leptomeningeal spread. Indications include medulloblastoma or other primitive neuroectodermal tumors, or disseminated germ cell tumors, a disseminated ependymoma. A special technique that can be used to deliver cranial-spinal irradiation is proton beam. The advantage of proton beam is that it avoids exit dose through visceral organs. This is an example of a proton beam plan. As you can see, the entire central nervous system, including brain, spinal cord, entirety of the thecal sac, are included in the cranial-spinal field. But as you can see, the color wash does not extend into the patient's visceral organs, thus allowing sparing of those organs from radiation dose.